Okay, hello and welcome everybody. Welcome to the webinar for this evening. My name is Patrick Grover. I'm one of the goal-based neurosurgeons in London and also a Gamma Knife Radiosurgeon. And for the next hour, we're going to be covering management of vestibular schwannoma. So we have a panel of speakers for the evening. We're going to start with Rupert Obholzer, who's an ENT skull-based surgeon who works here at Queen's Square and also at Guy's and King's. He's going to give us a broad overview of vestibular schwannoma management, including surgical aspects and the indications for treatment. Then John Sutton's one of our physicists, and he's going to be talking specifically about stereotactic radiosurgery and how that treatment is applied to vestibular schwannomas. Then I'm going to go through some more general aspects of Gamma Knife Radiosurgery and a few cases. And finally, we've got Andrew Reid, who's one of the trustees of the British Acoustic Neuroma Association, who's going to give a patient perspective. We're very keen for questions. We're going to do a Q&A at the end for 20 minutes. So if you do have some questions, please put them in the chat. I think we've got over 400 people registered, so hopefully we can get a few good questions to stimulate discussion for the end. To start off, I'd like to introduce Mr. Obholzer to take us through more general aspects. Rupert.
Yeah, okay, great. Hi, so welcome. Yeah, as Patrick said, I'm Rupert Obholzer. I'm an ear, nose and throat and skull-based surgeon. So basically deal with problems with the ears and with territory around the ears and extending into the head. So I'm just going to give a brief overview of vestibular schwannomas and what they are, what they do, and how we manage them. So, okay, so basically vestibular schwannomas. So what is it? The first question that tends to come up, well, is it a brain tumor? I mean, basically, it's the same thing as an acoustic neuroma. So the name was officially changed many years ago, but both names remain current. We are supposed to call them vestibular schwannomas, but because that's what they are, a schwannoma implying a lump of Schwann cells, and the Schwann cells are the cells that form insulation around a nerve. So for some reason, the Schwann cells around the vestibular nerve are much more prone to forming lumps than around any other nerve. Nobody really knows why that is the case, but it is. And that's the nerve that runs between the ear and the brainstem. So is it a brain tumor? Well, lots of trusted sources would say it is. Here's our trusted NHS webpage saying an acoustic neuroma is a benign brain tumor, but actually, you know, it's not actually arising in your brain. So I would say it's not a brain tumor. I think people find the idea of a brain tumor much scarier than the idea of a tumor that's within the head. But it falls into the broader category of brain tumors, and along with pituitary tumors, which are also not actually within the brain, and meningiomas. So from a reassurance perspective, not a tumor arising within someone's brain, but a tumor which can impact upon it. All right, so yeah, basically these things will tend to grow very slowly. There's a very small chance of them changing suddenly. Sometimes that's prompted by a bleed into the tumor, but the likelihood is it'll either change slowly or not at all. The smaller the tumor is, the less likely it is to grow. And the very small tumors, the ones that arise within the canal that carries the nerve in the bone out to the ear, the majority will remain stable. The likelihood of this ever turning into anything else is almost nothing. Okay, people always worry that you tell them it's benign and they say, but could it turn into a cancer? The answer is pretty much no. I mean, it's not absolutely impossible, but it's so stunningly rare, it's not even worth thinking about. Okay? But the loss of function that you get can occur relatively quickly. So there's a classification system for these, as for everything else, 1 to 4, and really the significance of the tumor varies greatly with its size. The classic symptom that a patient will present with a vestibular schwannoma is hearing loss or tinnitus. So this is a hearing test, and I'm not really expecting anyone to read this, but basically the further down the mark is in the box, the louder the sound has to be to hear it. This is the right ear, this is the left ear. And this is when you're listening for a beeping noise. But more significantly, this is what's called a speech audiogram, listening for words. And if you have a hearing loss related to the cochlea, as the words get louder, you will make out more of them. But if it's related to the nerve, as the hearing loss associated with a vestibular schwannoma is, you basically reach a ceiling and you can't make out the words however loud they are. How do they present? Well, quite a lot of them these days just get found by chance. Somebody has a scan because they've fallen off their bike or had a headache or whatever, and you find it as a chance finding. Sometimes patients have hearing loss, and associated with that sensory neural hearing loss, sometimes they have tinnitus. Okay? A lot of the patients will have a slightly underactive balance function on the affected side and will tend to veer towards the affected side. And sometimes people with larger tumors might develop a facial numbness or even headaches, pressure-related headaches, that kind of thing. But basically, sensory neural hearing loss, and then if someone's got facial numbness, then that really is the sign there probably is something more significant going on. The symptom varies slightly. The tumors can arise either end of the nerve. The ones that arise further away from the brain tend to be more associated with hearing loss. The ones that arise nearer it, perhaps more likely to present with numbness. What happens if you do nothing and someone's tumor is just left forever and ever? Well, the worst case scenario is it starts to squash their brain sufficiently that they die. We don't know that that would happen if we didn't treat these tumors, in that we know that some of the tumors stop growing on their own or shrink on their own, but obviously the vast majority of the time the tumors are found at the small stage and monitored, and if they show signs of growth, they're treated. So, you know, it's extremely rare for one of these things to be associated with that sort of an outcome. But we wouldn't want to wait until we were nearly there, because the risks of treatment increase as the size of the tumor increases. So basically, once it's clear that the tumor is progressing, we tend to advise treatment. The symptom which is most associated with the vestibular schwannoma of hearing loss doesn't actually correlate with the size of the tumor. So sometimes people have a lot of hearing loss with a tiny tumor, or a large tumor with very little loss. And similarly, you can't measure hearing as a way of monitoring the tumor, because their hearing can drop without the tumor growing, or conversely, the tumor can grow without the hearing changing. So the basic rule of thumb is that stable tumors are managed conservatively and normally not treated. If a very small tumor is growing, we generally wouldn't treat it until it's become something slightly larger than that smallest intracanalicular size. But if a tumor that extends into the space the brain sits in is clearly growing, then we would advise treatment. And if that tumor is small, treatment is almost invariably in the UK radiosurgery. And if it is large, i.e. more than 3 centimeters, then the treatment is almost invariably surgical resection. And there's a middle ground where there's a bit of debate about what the right thing to do is. Sometimes we would advise surgery for smaller tumors in exceptional circumstances, such as if someone's got very disabling vertigo or a lot of pain associated with the tumor, but these are not normally painful. So that is the sort of basic summary of what a vestibular schwannoma is and how we would generally manage it. Okay, I'm going back to the team now.
Thank you, Rupert. That was an excellent, a very clear summary. So Rupert's going to be with us to the end in the Q&A. If you have any questions, please, if you do have questions, can you put it in the event chat rather than the Q&A, and then we'll pick those up at the end. So our next speaker is John Sutton. He's one of our physicists who's really takes the lead in planning the treatment on the day of stereotactic radiosurgery, and he's going to take us through an introduction to that and some of the features of stereotactic radiosurgical treatment.
Great, thank you, Patrick. Good. So my name's John. So yeah, as Patrick says, I'm the principal physicist at Thornbury Radiosurgery Centre in Sheffield. And it's a pleasure to be speaking to you this evening on the subject of gamma knife treatment planning for vestibular schwannoma. So for the next 10 minutes or so, I'm just going to give a brief overview of the treatment planning process. And then I'll focus in on some specific parts of that process, looking at pre-treatment imaging, target delineation, and dose planning. And then I'll finish by just touching on lightning, which is a relatively new innovation in gamma knife treatment planning. So the planning pathway kind of begins at the start of the day when we fit the stereotactic frame. So this is screwed into the patient's skull under local anaesthetic. And the main purposes of the frame, it immobilizes the patients so they're completely still for their pre-treatment imaging and for their treatments. And it provides us with an external reference so we can target what's inside the head with reference to the frame on the outside of the head. The patient then goes for some MRI imaging. And then we can delineate or outline the target and any critical structures that we want to avoid. Dose planning can then commence. This is where we work out the best way to deliver the radiation dose to the target while sparing the surrounding healthy tissue. Pre-treatment checks are then carried out. So one of these is we acquire a cone beam CT scan immediately before treatment, and that just checks that the frame hasn't moved since the MRI scan. And then the patient has their treatment, which, if you're not familiar with Gamma Knife, basically the patient lies with their head in the center of the Gamma Knife machine, and the Gamma Knife contains nearly 200 cobalt sources. So they are moved into the treatment position, which causes these beams of radiation to be focused on the patient, and we position the patient so that those beams intersect in the tumor. So the tumor gets a really high dose, but the surrounding tissue gets a very, very low dose of radiation. So like I said, I'm just going to focus today on imaging, target delineation, and dose planning. So the patient will typically have 2 MRI scans, a T1 weighted scan, and the primary use of the T1 is to visualize the target, but also to localize it, so to specify its position in space with respect to that external frame. And it's used to define the skull, so that's necessary in order to model the radiation beams as they pass through the patient's head. We need to know the extent of their skull to do that. And here's a typical T1 weighted image. So the schwannoma is highlighted there by the orange arrow, and that's enhancing brightly due to the gadolinium contrast. The blue arrow there, that just points to one of the fiducial markers that we place on the frame. So that's kind of how we localize the tumor with respect to that external frame. We can specify its coordinates with respect to those fiducial markers. And then the T2 weighted scan, that just gives us some extra information about the target. And it's also really good for visualizing the cochlea, which is a really key, what we call an organ at risk, so to avoid. And here's an example of a T2 scan. Again, the orange arrow there just pointing to the target. And here's just a comparison of T1 versus T2. And you can see the cochlea there outlined in red, and it's much more conspicuous on the T2 scan. So next we can do target delineation or target outlining. In our centres, this is typically performed by a neuroradiologist, and it's a really important task because the entire treatment is based on the target as we've outlined it. So it really needs to be as accurate as possible. And like I mentioned, we would outline it on the T1 scan, check it on the T2, and then the T2 can be used for the cochlea as well. And here are just two examples. On the left is a fairly typical shape and size for a schwannoma. On the right is a much more complicated shape, indenting the brainstem quite significantly. And the total width there is about 30 millimeters. So based on what Rupert was saying, this would kind of be at the limit of what we can treat with stereotactic radiosurgery. Dose planning can then be done. So this is performed by a medical physicist, such as myself. And we do this by placing shots inside the target. So if you're not familiar with Gamma Knife terminology, a shot is basically a small sphere of radiation dose. And we can pack the tumour with these spheres of dose in order to adequately treat the tumour. Each of those spheres corresponds to a patient position in the machine where those beams of radiation are intersecting each other. And here's an example from our treatment planning system, the software that we use. So this is a single shot being placed inside the target, shown by the yellow line. Everything inside that yellow sphere is receiving higher than the prescription dose. Everything outside the yellow sphere is receiving lower than the prescription dose. And this is a good starting point. We can see we've covered the sort of central bulk of the tumour, but the stats there show that we're only covering 44% of the total tumour volume. So we can add more shots. So this is after we've added 2 more shots, one above and one below the primary shot. And you can see how that's deforming the yellow line, which represents the prescription dose. And it's starting to take on the shape of the target as we add more shots. The coverage has increased to 64%. Now the selectivity is 95%. What that means is 95% of the prescription dose is contained within the tumour, and the remaining 5% is spilling outside of the tumour into healthy tissue. So we want selectivity to be as high as possible. And the gradient index, that's just another way of describing how quickly the dose decreases as we move away from the target into healthy tissue. And we want that number to be less than 3, ideally. So we can continue adding shots. The shot size can vary from 4 millimeters to 16 millimeters. And I said that the shots are spherical, but we can also shape them as well and sort of make them more elongated. And I'll talk more about that in a second. So really the aim of what we're trying to do is to cover the boundary of the target with the prescription dose, typically 11 to 14 gray, while minimizing dose to healthy tissue, paying particular attention to the brain, the brainstem, the cochlea, if the patient has useful hearing on that side, and the facial nerves. So this is a plan which I produced myself for the purposes of this demo. I think we've got about 15 shots on here. Coverage is pretty good. Selectivity is still quite high. And you can see how the prescription dose is conforming to the shape of the target. But there are still some improvements that can be made. So on the anterior or the front surface of the target, we can see the dose hit, and we really want to avoid this, particularly on this part of the target, because this is where the facial nerves run along the surface of that side of the target. And the green line, that shows the 4-gray dose, and 4-gray is a typical tolerance dose that we typically use in clinical practice for the cochlea. So at the moment, the cochlear dose is exceeding the tolerance. This slide shows the plan after some small adjustments to move the shots away from that front border, and you can just see how that dose, I'll just flick between the two. So that was before. If you keep your eye on the central arrow, and that's after. So now the dose is much tighter on that anterior edge, which reduces the risk to the facial nerves. But the cochlear dose is still quite high. So what can we do about that? So this is a bit more difficult to deal with. What we can do is we can shape the shots near the cochlea. So if you look at shot 12 there, that's now very elongated. And that's been done by blocking the radiation from certain directions. We can block radiation from entering through the cochlea, and that kind of squashes the dose and pulls it away from the cochlea. And this can be done manually, or we can use something called dynamic shaping. This is an automated feature within the software, where the software automatically works out the best configuration for the blocking in order to spare the critical structure, i.e. the cochlea. The coverage has reduced slightly, and that's often a trade-off that you have to make between coverage and sparing organs at risk, and also just limiting dose to normal healthy tissue. So dynamic shaping, that brings me nicely on to lightning. So with dynamic shaping, I place the shots manually, and then the software automatically works out the best way to shape them. With the lightning algorithm, both shot placement and shaping are automated, and the algorithm optimizes the plan based on objectives which the physicists can specify. So the different objectives are tumor coverage, avoiding any so-called risk zones, such as the cochlea or the brainstem. Low dose, that's just reducing dose to normal tissue. And also beam on time. So that can be set as a high priority if you want the patient to have a really short treatment. Not usually a big concern in these cases, but yeah, so we would normally prioritize maybe low dose and risk zones, and accept a longer treatment and maybe slightly suboptimal coverage in a lot of cases, but it varies on the case and the patient, of course. And here's a plan I produced with lightning. So it's not perfect. You can see a bit of dose spilling out in the bottom right corner of this image. But, you know, it literally took me about 20-30 seconds to produce this plan. So, you know, it's an excellent starting point. And here are some statistics. And although maybe I've picked a slice where it doesn't look too great, in terms of the statistics, the lightning plan is actually better than mine in every respect. And with further tweaking, it can be improved further. So this has been a really fantastic innovation, which is really good for patients. So thank you for listening, and I'll hand back over to Patrick.
Thank you, John. So that was an excellent overview of how we plan and deliver the treatments. Now I'm going to give a quick case presentation and then just take you through some of our data from Queen's Square. So if you give me 2 seconds, I'll load up my presentation. And this is a 55-year-old lady, and she presents with right-sided hearing loss vertigo, and imbalance, which really is the very typical presentation for these tumours. This is, we would conduct audiometry, as Rupert was explaining, so you don't need to interpret this, but essentially there's more right-sided hearing loss confirming type of hearing loss we tend to typically see in vestibular schwannoma, and this is the kind of audiogram which would then stimulate an MRI scan. And the MRI scan shows here in the hearing canal a small tumour. So at the moment it's situated within the canal and it's a few millimetres. If you compare with the canal on the other side where there's no tumour, you can see the nerves passing through freely. But this is the starting point often for these tumours, that they're very small. This particular patient then missed some follow-up scans. Normally we would do a 6-month scan and then a yearly scan after that. But the next scan in this case didn't happen for 4 years. And you can see now that the tumour has grown out of the hearing canal and it's gone into this region, which is growing towards the brain. So this is the brain stem, and this is the cerebellum. Now that tumour has grown all the way along those nerves, and it's just pushing slightly towards the brain stem. And you can imagine, if you let it another 4 years, it would probably grow to a larger size here and be indenting the brain stem significantly. So we classify these tumours according to that pattern of growth. So for stage 1, confined to the canal, they're Qs. This is one classification, actually many classifications, but this is just to give you an idea. Stage 1, they're confined to the canal. Stage 2, they emerge from the canal and make their way towards the brainstem. Stage 3, they come up to the brainstem, and stage 4, they're really pushing into the brainstem. And that's correlated with the sizes that Rupert was describing, and also that's very much how we decide on what treatment is best. This particular case we felt was suitable for Gamma Knife Radiosurgery, and that's because it remains small. It's small enough for radiosurgery, and it's not causing significant mass effect on the brainstem yet. If it was causing more significant indentation and mass effect, then we would most likely have opted more towards open surgery to relieve that pressure on the brain. So we just discussed how radiosurgery is conducted. This is a patient going into the Gamma Knife machine, and with the frame on that you can see there. Frame itself we tend to fit first thing in the morning, so we start around 7:30, and putting on the frame takes the best part of 5 minutes. It's a bit like a trip to the dentist, so you have local anaesthetic infiltrated at 4 sites, and then the pins are screwed in. This is the older frame, which is called the G frame. Really, for most patients now, we use this new frame called the Vantage frame, the blue frame, which is carbon fibre. The pins are a much lower profile. It's open at the front, so you can eat and drink during the course of the day. You know, I think it's a great improvement, really, on the older frame. This is a typical plan and a treatment. So this treatment took 38 minutes. That's the kind of tumour that we were treating. We tend to give a dose of 12 Gray. Some of the older series in the literature are more sort of 13, a slightly higher dose, but we've found that with a lower dose we can achieve the same results. And that's the spectrum of volumes that we treat. So mostly we're treating the small tumours, but occasionally there will be patients who are not suitable for surgery, or obviously patient preference. We might end up treating larger tumours as well. So this is the tumour now treated. So this is before treatment on the left panel, and on the right panel that's after treatment. And you tend to see this typical appearance of what we call central necrosis. So the centre of the tumour goes black, and that suggests to us that there's been some response to the treatment, and hopefully then it will stabilise or even shrink. This is an overview of the treatments that we do at Queen Square with Gamma Knife, and vestibular schwannomas are a percentage of the total, and we do lots of other kinds of tumour and pathologies in the brain, vascular malformations, for example. As a percentage of the whole, the vestibular schwannomas is about 20%. We tend to treat on average about 50 a year. This data is from before COVID, but has remained about the same from a vestibular schwannoma perspective. We treat primary tumours. About 80% of the tumours we treat have never had any treatment before, and about 20% of the tumours we treat have had surgery before. And that percentage has increased because we have found actually that with this concept of facial nerve sparing surgery, we tend to, when we operate on the larger tumours, we tend to leave an amount of tumour behind on the nerve that moves the face, because from experience, if you try and take all the tumour off that nerve in a large tumour, unfortunately it tends to often stop working, and then you can get a facial paralysis or weakness. So by doing facial nerve sparing surgery and leaving that part of the tumour behind, we find that we can then treat that residual with Gamma Knife, and that combination is enough to control the tumour in the long term and also preserve facial function. So the number of residuals that we're treating has increased over the last few years. We've got a series, we looked at 250 patients we treated over the last few years, and I'm just going to take you through some of the patterns of treatment response. Our tumour control rates at Queen's are about 91% at 5 years. So of all the ones that we select for treatment, 91% have tumour control at 5 years. 3% of those have gone on to have surgery, so they've really failed Gamma Knife treatment and had an operation. And about 6% of those that were left are still growing at 5 years, but we're continuing to survey. So they may stop, or they may end up having surgery in the long term. And that's equivalent to the Pittsburgh series. They were really one of the founding centres for Gamma Knife for vestibular schwannomas, and their results are essentially exactly the same. So 91% tumour control, 97% resection-free control at 5 years. We see different patterns of response. This is a 71-year-old gentleman, standard treatment, and he's got quite a large tumour here, which has shrunk down significantly on treatment at 2 years and 3 years. So that's really a dramatic response, volume reduction of 87%. I wouldn't say that's the norm, but that's a very good result. And we see volume reduction in our series in about half of the patients. So after treatment, the tumour does shrink in many patients. And about 25%, so 1/4, we see an initial swelling, so initial progression of the tumour, and then a response. And that can happen at any point in the next 1, 2, 3 years. That grows a little bit or increases in size a little bit, and then it shrinks down. And then in another 1/4 of the patients, the tumour continues to enlarge. Year 1, year 2, year 3, and even year 4. And for these patients, we get into this debate about whether that's actually growth of the tumour or if it's something called pseudo progression. So prolonged swelling of the tumour that eventually will settle down. And what we have found is as long as the patient is not having significant symptoms or complications from mass effects on the brain, if you continue to watch these even at year 3 or year 4, eventually a good proportion of those do stop growing or stop increasing in size. So a lot of these are actually what we call pseudo progression and not true growth. They do eventually respond. Hearing preservation. So this has been a source of debate. I think in broad terms, a lot of the series and the literature will say that the overall hearing preservation rate is about 50% at 5 years. So 50% of patients who have Gamma Knife of all sizes of tumour will have preserved serviceable hearing, so useful hearing, meaning you can use a phone in that ear, for example, at 5 years. And of those with good initial hearing, so that actually have very good hearing at the beginning, you can preserve hearing at 5 years and up to 80%. So that's quite a significant improvement on most surgical series. You can do hearing preservation surgery, but most series would not achieve quite the same results. And that correlates with the dose of the cochlea, as John was explaining. So if the tumour is further away from the cochlea and we can minimise the dose to the cochlea, then your chance of preserving hearing in the long term is better. If the tumour is very close to the cochlea, so we have to give radiation to the cochlea, then your chance of hearing preservation is So what about side effects? So as with any treatment, I'm afraid it's not risk-free, but the rates of side effects is pretty low. The reason why we get side effects is because of these nerves, which are either part of the tumour or stretched around the tumour. In particular, the facial nerve is the nerve that moves the face, the cochlear nerve, the hearing nerve, and also the vestibular nerve, the balance nerve. So all of these nerves are either part of the tumour or compressed by the tumour, and if they're irritated by treatment, you can get symptoms from that. Balance problems are the most common symptoms that we see from Gamma Knife. This is a patient who had a good treatment response, so you can see the tumour is gradually shrunken down, but unfortunately did suffer from significant balance difficulties with vertigo, and that can last for a variable period, weeks, months, or even years. Usually, in the long term, balance problems settle down, and that's because eventually the balance nerve on that side stops working, but you still have a normal balance nerve on the other side. And once the brain has got consistent signals, it can eventually figure that out, and eventually your balance will return to near normal, or certainly it won't be as significant a problem as when there's swelling, inconsistent signals, and then you can have quite prominent vertigo. The other complication we worry about is facial droop. We certainly worry about this more with surgery. In most surgical series, depending on the size of your tumour, your rates of facial weakness after operation would be at least 5 or 10%, which might be temporary or permanent. With radiosurgery, the rate's 1%, or in our series, 1.7%. We had 2 significant facial palsies in our series, and both of those recovered to a reasonable grade, so a sort of partial asymmetry rather than a complete paralysis. So Gamma Knife is a very good treatment in terms of an extremely low risk of causing facial weakness. It can be quite severe and quite debilitating if it does happen. Hemifacial spasm is twitching of the face. We saw that in 4% in our series. It can be treated with Botox, for example, and often is a temporary phenomenon. Facial numbness or trigeminal neuralgia. The reason this occurs is because there is another nerve, the trigeminal nerve, which is displayed over the top of the tumour, and that can also be compressed and irritated. If it's compressed and stops working, you will have a numb face, and if it's irritated, you can get shooting pain in the face. In some patients, that can be very severe. Usually it's treatable with medication. If you really have a lot of compression of the nerve from a tumour, often the best treatment is actually surgical decompression. But if you had Gamma Knife, it's unpredictable, I would say. So it's unpredictable if that might cause facial pain or if it will get better. More severe side effects. In 4%, we saw this phenomenon called radiation edema. So that's this white signal you can see in the brain here. That's swelling after treatment, and it's quite unpredictable when that happens. Usually it would be a larger tumour. It's probably because of breakdown of the blood-brain barrier and release of factors into the brain that causes a swelling response. It tends to be a temporary thing, but it can last for months. And if it occurs, we will give steroid medications over a few weeks, for example, and eventually it will settle. But that can cause a lot of symptoms for that period until it does settle. And then here is an example of a treatment failure. So this is a patient with quite a large tumour. And you can see that they have had initial response. So in the middle panel, the tumour has got evidence of necrosis in the middle, so the central part of the tumour has died. But then the next follow-up, a year later, it's swollen significantly. It's grown a lot, and now the brainstem is quite compressed. So this patient then had rescue surgery. And I think, I'm not entirely sure what the rationale was for the treatment at the beginning. It may be that they were felt not to be suitable for surgery at the beginning, or patient choice, but certainly the larger tumours, if you do treat them, do run a risk of treatment failure and then running into symptoms and needing operation. In terms of research, we're doing a lot of work at Queen Square at the moment, mostly using AI and imaging techniques to quantify response to treatment and also to find predictors of response. So in particular, we're trying to use AI algorithms, which we've published, to determine what the features are of the tumour before we treat them that then predict either treatment response, treatment failure, or these complications and side effects. So that's really the focus of our research portfolio at the moment. That was a whistle-stop tour through radiosurgery for vestibular schwannoma. Now we will do questions at the end. I've just stopped sharing, and then I'll introduce Andrew Reid. So he's a trustee of the British Acoustic Neuroma Association, and he's just going to give us the patient's perspective for the next few minutes, and then we will go on to questions afterwards.
Hello, thank you, Patrick, for that. Good evening, everyone. My name is Andrew Reid, and I'm representing Valentine, British Acoustic Neuroma Association. I'm a acoustic neuroma patient. I had translab surgery to fully remove the tumour back in May 2017. I've been a volunteer over 4 years now for Banner. Hosting virtual support groups. Also, I say I've been a trustee for a year, and I've done many fundraising challenges. I'll just give you a bit of background about Banner. Banner was formed in 1992 by a group of patients and their partners. They were introduced to each other by the ENT and neurosurgeon consultants from the Queen's Medical Centre Hospital in Nottingham. From the very beginning, mutual support was their primary aim. Also, they wanted to provide reliable information to those diagnosed and promote research in acoustic neuroma and effects associated with them. More than 2 decades on, these fledgling intentions remain the charitable objectives that drive the charity forward on behalf of all those affected. Banner continues to provide and develop support the patients in the support network, offering access to local support groups run by volunteer hosts, subject to the availability in the area, access to the Listening Ear project, which incorporates volunteer members who have agreed to offer peer-to-peer support, seasonal headline magazine, news magazine, free information sheets online on our website, online website forum to discuss topics with other members, access to our closed Facebook group, hire of electro simulators for treatment of facial palsy under medical supervision, access to the medical advisory panel made up of prominent medical practitioners, opportunities to attend our yearly conference, fundraising support, volunteering opportunities in the UK. Banner is entirely self-funded, and we receive no statutory aid or sort of rely on charitable donations and our modest membership fee, fundraising amongst the Banner community. We have over 500 members, so if has anybody heard of Banner or would like to get involved in more in Banner, or a volunteer or a trustee, we're always we always appreciate anybody getting involved that way. So if anybody would like to know more about Banner, but I think Sophie, I've sent the link to Sophie. So I think that's all right, Patrick.
Thank you, Andrew. That's excellent. So the British Acoustic Neuroma Association has a very good website, lots of information on there and contact details if you're interested in supporting them. And I'm mindful we've got about 10 minutes for questions. So I'm just going to go through some of the questions that have come through on the chat. First question is for Rupert. This is from Melanie. And the question is, although hearing loss is not correlated with the size of the tumour, is there any relationship between the degree of hearing loss and the location of the vestibular schwannoma?
Okay, so yeah, good question. Basically, the cochlear bit of the nerve, the bit that does the hearing, is not normally the bit in which the tumour actually arises, but it gets pinched by the tumour, and that leads to the hearing loss. At least that's the assumption. And so that tends to be within the bony canal. So basically, a tumour that's arising on the lateral bit of the nerve, the bit that's in that internal auditory canal, tends to be more associated with hearing loss than a tumour that is arising nearer the brain. So basically, if one is much nearer the brain, it can grow without being confined by bone, and so the cochlear nerve is less likely to be pinched. So basically, it would be very rare to see a small tumour of maybe, you know, a few millimetres or a centimetre in the cerebellopontine angle, i.e. not surrounded by bone, which causes hearing loss. It's the bit of tumour arising within a confined space that tends to be associated with the hearing loss. So that's why the correlation is sort of poor. But yes, there is a location thing. There's a flip side, so that the more lateral tumour might cause more hearing loss, but then it might be less likely to be squashing your brain. So swings and roundabouts.
Thank you, Rupert. Yeah, and that, you know, really affects us. We're talking about the gamma knife treatment. So the closer it is to the cochlea, the more likely you are to lose hearing with gamma knife. There's another question for you, Rupert. If there's asymmetrical sensory neural hearing loss, how large does the asymmetry need to be to warrant further imaging investigation?
Okay.
Particularly if there are no other otological symptoms.
Yeah, excellent question, and source of endless debate. Essentially, you'll find a very good paper, 2004. Hard to believe I could have possibly written the paper so long ago on this, which basically suggested we did an analysis. And looked at things called ROC curves, receiver operator characteristic curves, to basically try and pick out the point at which you should draw the line, as in who warrants a scan and who doesn't. The conclusion was that if you had single-sided hearing loss, a difference in two adjacent octave frequencies of 15 decibels, so basically two adjacent frequencies with a 15 decibel difference between the two ears in those frequencies, was enough to warrant a scan. But if you had that's if the other ear is normal. It's quite often the ones where one really debates whether or not to get a scan is someone who's got a degree of hearing loss in both ears, but one is worse than the other. And our study suggested that in those cases, you could accept a slightly smaller, that level of loss could be accepted as normal, and you would want a 20 decibel difference between the two sides. The caveat being, you might say, well, what is the downside of setting the threshold lower? I.e., you know, why would you not scan someone who's got 10 decibel difference of two frequencies, or 5? And the answer is just, well, twofold. One is you end up ordering an awful lot of scans, and maybe that doesn't matter, but in some systems, the there's an implication in terms of cost and resource availability. You know, if you haven't got many scanners, do you need to target them at the people who are more likely to have a problem? And then the other sort of downside is that, you know, when you say to someone, "Oh, I'm nothing to worry about, but I'm just going to get a scan to make sure you haven't got a tumor," obviously that also provokes anxiety. A patient then has to wait for the scan. They then have to wait to get the results. You know, there is an impact from doing the test. So basically, I would say about 15 decibels at 2 adjacent frequencies is my cutoff. But if there's anything else suspicious, deep-seated ache, tendency to veer, any hint of numbness, anything like that, then I would just get a scan anyway.
Okay. Now we've got a question for John. The question is the tumor experience of pseudo growth at 6 months following Gamma Knife treatment. What is how long does that swelling last? John, is that a question you'd like to answer, or shall I tackle that?
How long does this? Well, I think pseudo progression can last for several years, I believe. Yeah, I have seen cases where even after 5 years, you know, the tumour seems like it was progressing before then eventually shrinking down. Yeah, that's all I know about that. Maybe Patrick, you can elaborate.
Yeah, I think it's well, this is a difficult question, and you know, we discuss this regularly in our multidisciplinary meetings, because it's really not clear how to make this distinction apart from holding your nerve and just waiting to see what happens. There's a similar question there which says, what's the difference between pseudo growth and swelling due to the effects of radiation clinically? So clinical features are not particularly useful. It really, for much of the management of vestibular schwannomas, we need to manage the symptoms, but in terms of telling us what's happening with the tumour versus the nerves versus swelling in the brain, the only way we can really tell that is on imaging. And then once we do the imaging, which tends to be an MRI scan once a year, we can certainly tell the difference between swelling in the brain versus swelling of the tumour, but we can't then tell the difference between swelling of the tumour or growth, so ongoing true growth. And the only way at the moment for us to do that is to wait and see. I suppose the other methodology that we do use is volumetric analysis. So that might get easier now that we have these image segmentation techniques and AI, which we can apply to tumours. But essentially, one feature you can look at is you can plot the volume of the tumour over time. So you plot that volume year on year, and if the volume, if that plot is gradually plateauing, it seems more likely that's pseudo progression, swelling. But if that graph is either proportionally increasing or exponentially increasing, it suggests actually that's growth. And in those situations, you're more likely to then recommend surgery rather than continued monitoring. Now, we have a question from Kay for Mr. Obholzer. What does the symptom of being off legs mean?
Okay, sorry, that's perhaps a slightly sort of flippant comment, but sometimes, sometimes what happens, it's not that uncommon for someone presenting with a larger tumour to have been told years before, perhaps, oh, don't worry about the hearing loss, you know, that's just, you know, not a concern. And then essentially people often don't really develop more symptoms until quite late in the day. Sometimes facial numbness as But if the brainstem's significantly squashed, sometimes people just get very non-specifically unsteady and sort of weakness, and will come, occasionally patients come in a wheelchair because they've lost the ability to walk in any sort of reliable fashion. So those are the sort of late stage symptoms of large tumours. I guess what it doesn't refer to normally is the situation where someone feels a bit unsteady, particularly say going downstairs or walking through crowds, that kind of thing, which just implies visual dependency for balance.
Okay, thank you, Rupert. So we're sort of coming to time now. It's 6:30. Dan, I presume we can't extend the webinar just to answer these last few questions. Is that right?
No, we can extend. We absolutely can extend, and you can continue to answer the questions.
Ah, okay, excellent. Right. So just go through some more of these questions then. Now, there's a specific question here. Is there a need for rehabilitation after the intervention? Does the treatment fall to physio or speech therapy or occupational therapy? And, well, the answer to that question is that there's not a specific need for rehabilitation unless you end up suffering from some of the symptoms or side effects that I described in my presentation. So the majority of patients do not need specific rehabilitation and go through the treatment, have minimal or if any new symptoms, and the tumour is controlled. There is a minority who have specific problems, say for example it's balance problems and vertigo, then specific balance physiotherapy can be very useful for that group. Speech therapy doesn't tend to be indicated, and occupational therapy I think very rare. So really it's the vestibular physiotherapy which might be the most useful in certain patients. Question about trigeminal neuralgia. So if trigeminal neuralgia results from treatment, is it likely to be temporary or long term? Well, the answer to that question is for most, well, I would say it's actually difficult to be certain about this, but I would say often it's temporary and then it's an aggravation and settles down, particularly if it comes on after a few months, because that's the peak swelling time. And then as the swelling goes down in the longer term, it's not so much of an issue. I would also say that trigeminal neuralgia is quite treatable with medications. So usually once it starts, we would treat it with a medication called carbamazepine, which is very effective. So for most patients it's temporary. I think you'd be unlucky if that's a long-term side effect. I've talked about the sort of uses of AI in the management of vestibular schwannomas. So as I said, really, we're looking at using those techniques for predicting treatment response and also correlating with symptoms and just trying to pick out features in the pre-treatment imaging that can predict what's going to happen after the treatment.
Maybe if I could add to that, Patrick, as well with AI. So, because AI is interesting. It's a very hot topic at the moment. And it is increasingly being used in more general radiotherapy. So in my talk, I talked about the tasks of target delineation and dose planning, and AI does have applications for both of those. And there was an article in the BBC News just last month reporting a study at the Adam Brooks Hospital in Cambridge, where for prostate patients, an AI algorithm was 2.5 times quicker than manual contouring, manual outlining of organs and of the tumour, and with 90% accuracy. So, and increasingly radiotherapy departments are starting to use this technology. Will it impact the Gamma Knife world? Possibly. I think vestibular schwannoma cases are usually fairly quick to delineate. You've just got the single target and then just 1 or 2 organs. And then with dose planning, with lightning, that's very fast as well. And already produces, very, very good good plans. So, you know, I'll sort of wonder, is the demand there for AI? Because it's a lot of effort to develop it, obviously. But we'll see. I think if it does become more widespread in the general radiotherapy community, then I think we could see it impacting radiosurgery as well.
Thank you, John. We have a speech therapist in the group who's just flagged that he has 3 post-op patients she's treating with facial palsies. And yes, absolutely, that is one potential avenue of therapy. If you're unlucky to have a facial palsy after gamma knife or surgery, then specific rehabilitation is certainly necessary, either speech therapy or with a physiotherapist, and even sometimes further procedures to reanimate the face if it's severe. But in our series, that complication thankfully is quite rare with gamma knife. There's a question, maybe Rupert, you could give your opinion on this. Do you ever see any neuropsychological adverse side effects after treatment in this patient group?
I think the answer to any question saying, is it possible, is yes, I'm sure it is, but it's very rare. And it's always difficult to tease out what is, you know, I mean, essentially, it's a stressful process going through the whole thing. You then have radiosurgery, the tumor swells up a bit, often people get more symptoms. It's disconcerting not knowing whether it's worked for potentially for several years. So, yeah, I mean, sometimes people say, look, I'm not as sharp as I was. I'm struggling, you know, brain fog is one of those sort of classic symptoms. I wouldn't want to dismiss it, but in terms of sort of the mechanisms, you know, the radiation dose to the relevant bits of brain is very small, so it shouldn't cause these problems. But yes, we see them sometimes, and it's hard to sort of pin down exactly why. I mean, I think the brain does remain a slightly mysterious thing in some respects.
Yeah, I would echo that. I mean, it's I wouldn't say it's typical. It's not something that's very well characterized, but you know, I do have some patients who have had a gamma knife or surgery and have quite non-specific symptoms. And maybe some of the work we're doing using AI and correlating that with clinical, with patient-reported outcomes, will tease apart some of that for the future. Now, this looks like a question for John. Does your prescription isodose change depending on the size of the lesion being treated?
The prescription dose. Yes, I think that would be a factor in deciding what dose you would use. Yeah, potentially for a larger tumour, it might be appropriate to use a lower dose. And also, I guess, if the patient's, you know, is really concerned about if they've got useful hearing and we really want to preserve that hearing, then we might use a lower dose again, just to help us reduce dose to the cochlea. Yeah, and I guess also how quickly the tumour's growing is important as well. If we want to be more aggressive for a faster growing tumour, or for a tumour that's compressing the brainstem, then we would want to be more aggressive and use a higher dose in that case.
Yeah, we don't tend to vary the dose very much. The vast, almost 90–95% get 12 gray, but there are specific circumstances that we might reduce the dose. And we have Catriona and Neville, who's a trained facial therapist, just flagging that she recommends Facial Therapy Specialists International or Facial Palsy UK if you do need any facial palsy rehab. So yes, I'd absolutely echo the importance of appropriate facial rehabilitation and physiotherapy if you do have a palsy. And as I said, there are lots of other methods as well to improve that situation if that has happened to you. So I think I'll wrap up there. Thanks to all our speakers, and thank you for the audience asking some very good questions. And there will be more webinars coming in the next few months and years on different kinds of pathologies and treatments. So we'll be sending those out through the same portals as this one. So thank you, everybody.